Now I'm going to talk about some definition of terms which are going to be used frequently in this presentation, and we should be familiar with to understand the mechanism and the process of the refractive errors, and how do we choose to prescribe for children. So first of all, emmetropia. It's a refractive state in which the parallel rays of light from a distant object are brought to focus on the retina in the non-accommodating eye. What does that mean? It means that in non-accommodating state, if the accommodation is relaxed, the picture will fall exactly on the retina, not in front, not behind. And this is different from emmetropia, which is the absence of emmetropia, which can be classified by, according to the presumptive etiology, according to the cause, into axial and refractive. So in axial, if the eyeball is short, this will cause hyperopia. If it is long, it will cause myopia. And refractive emmetropia, in case of refractive power of the anterior part of the eye, the cornea and the lens is excessive, it will cause myopia. If the refractive power is deficient, it will cause hyperopia. Okay, what is myopia? Myopia, this is, of course, it's a basic knowledge, but because the lecture is intended toward resident teaching, so I'm going to talk about each type of refractive error quickly. So myopia, it's a condition in which when the accommodation is relaxed, parallel light of rays from infinity focus to a point anterior to the retina, forming a blurred image. As in this example, we can see here, the picture is in front of the retina and it will be corrected by concave lenses. Hyperopia, when accommodation is relaxed, parallel light of rays from infinity focus to a point posterior to the retina. We can see here the picture is formed posterior to the retina, and it will be corrected by convex lenses. Also, hyperopic can be divided into latent and manifest. The latent is the part of the hyperopic which will not be it will not be manifested, and it will not be discovered until cycloplegia is used. Astigmatism, it's an optical condition in which the eye, in which light rays from the object do not focus into a single point, but instead it will focus into two focal lines or more. So instead there is a set of two focal lines. You see here, more than two focal lines. It will be corrected with this type of lenses. Again, astigmatism can be divided into regular and irregular. The regular type of astigmatism when there are two principal meridians separated by 90 degrees. And the irregular type of astigmatism when there are more than two principal meridians are not separated by 90 degrees. And this picture will clearly illustrate the difference between each type. This is the normal eye, almost spherical shape. And this is in the case of regular astigmatism. It's like an oval shape, or sometimes they call it American football shape. And this is the irregular astigmatism. It has no specific shape and more than 2 meridian. Again, the regular type, it's divided into with the rule, against the rule, and oblique. In the case of with the rule astigmatism, the vertical meridian is the steepest, and it will be corrected by plus cylinder lens at axis 90. And in the case of against the rule, the horizontal meridian is the steepest, and it will be corrected by positive cylinder lens at axis 180. In the case of oblique astigmatism, the principal meridian is 30 degrees away from the vertical and the horizontal meridian. So it will be either at 45 or 135 or in between. Spherical equivalent is the algebraic summation of spherical component and half the astigmatic part. So, for example, if the prescription is plus 3 minus 1 at x 180, the spherical equivalent will be plus 2.5. And then anisotropy refers to any difference in the spherical equivalent between the two eyes. Now I'll talk about some developmental aspects which need to be understood clearly to help you to understand why we undercorrect sometimes, why we give full correction in some other situation. First, immotorization. It's a process by which the refraction of the anterior ocular segment and the axial length of the eye tend to balance each other to produce emmetropia. The rate of emmetropization is generally proportional to the initial error. So, for example, if the initial error is high, the rate of emmetropization will be high. If it is low, the rate of emmetropization will be low. Children will have higher accommodative ability than adults. This is clear for everyone. Then the amplitude of accommodation can reach up to 12 diopter in children in their first decade. And this is why sometimes some situation you will find a child have a reading of -6 or -5 in auto-refraction, and also if you do manual retinoscope refraction, you'll find his refraction is against and he is myopic, and sometimes they have a blurred image. Then when you do cycloplegic refraction, you'll find him plano or sometimes hyperopic. This is because of a strong accommodation in pediatric. Presence of strabismus is associated with lack of emmetropization, as documented by some studies. This graph will show you that the high refractive error children are less likely to emmetropize. Why? We can see here in the graph. This is a graph showing the probability of emmetropization for a 3-month-old versus the spherical equivalent refractive error in 3 months. The probability of emmetropization for against the spherical equivalent refractive error at 3 months. So, for example, if an infant who is 3 months old has a refractive error of spherical equivalent of 5 diopter, his chance and probability to emmetropize will be less than 50%. So if you go higher with the spherical equivalent, his chance for emmetropization will be lower, as we see here. I hope everybody understand this curve or this graph. Okay. Natural history of refractive error. Natural history means that what are the normal refractive error for each age, and also what will happen to each refractive error during development. So first, at birth, most infant at birth, they are hyperopic, and the average cycloplegic refractive error is approximately +2 at 3 months. Then in the first 3 months, the average refractive error usually increases. This is a short period of increase in the spherical equivalent refractive error. Then from 3 months to 12 months, there is a period of fast emmetropization. Then from 1 year to up to 2 years, the period of slower emmetropization. And we know that the emmetropization almost stops in all types of refractive error at approximately 4 years. For myopia, few infants are born with myopia, and most of these will emmetropize with time. Emmetropization will continue until 4 to 5 years in case of myopia. In case of astigmatism, high prevalence of infants at birth having astigmatism 1 diopter or more. In most population, there is a decrease of both prevalence and the degree of astigmatism in the first few years of life. Here, very important notice that the oblique astigmatism is the least common type of astigmatism in pediatric. So the oblique astigmatism is a risk factor for amblyopia, and we have to take this into consideration. Anisometropia, studies have shown that anisometropia is more common in infant than adult. That means the child with anisometropia usually tend to decrease with time, but some anisotropy, if it's high, it will not. As we see here, anisotropy relatively lower level, less than 2 diopter or less, will resolve and decrease, but higher level of anisotropia, 3 diopter or more, are not likely to improvise or to improve. This table or this paragraph is showing multiple studies of different studies showing the means spherical equivalent and upper and lower 95% limit. One minute. So, for example, here in the study of Meyer and colleague, at the age of 2.5 months, the mean spherical equivalent is 2.4 diopter, and the lower 95% range, that's mean the 95% of population at the age of 2.5 months, the lower limit for them is minus 0.3, and the upper limit is 5 diopter. And let's concentrate here from this age, 2.5 months equal to 3 months, up to 1 year, 12 months, we can see that the spherical equivalent getting less and decreasing, and also the range is decreasing. Instead of 5 diopter range, it becomes 3 diopter range, and the lower limit will be plano and the upper limit 3, and also it will continue to decrease with time. So at the age of 3 years, the spherical equivalent is the mean spherical equivalent is 1 diopter, and the lower limit is minus 0.6, and the upper limit is 2.6. Okay. Right. Now, when considering prescribing glasses for children from birth to 6 years, there are some questions need to be answered, and you should think about it. So, is the refractive error within the normal range of the child age? Will this is important. So, if it's not within, if it is within the normal range, you may think not prescribing glasses. If it is within the normal range, you may think. If it's not within the normal range, you need to prescribe. Will this particular child refractive error emitter-wise? So as we know that some refractive error will emitter-wise. If it's high refractive error, it will not. So you need to prescribe glasses. Will this level of refractive error disrupt normal visual development? Will this level of refractive error disrupt normal visual development or functional vision? For example, high refractive error or anisometropia. Will prescribing glasses improve visual function or functional vision? This is also clearly demonstrated by many studies that prescribing, for example, moderate astigmatism in a pre-verbal child will improve his functional vision when he gets older. Will prescribing glasses interfere with the normal process of immobilization? Yes, this is a very important question. For example, if you have normal refractive error for age, for example, you have a child who is 2 years and his bilateral refraction is +2. So if you give him full correction, you will interfere with his normal process of immobilization. Hence, most guidelines for prescribing glasses in children are based on clinical experience rather than randomized masked clinical trials. General criteria is to suggest prescribing if the refraction is outside the 95% limit for a particular age. If it is within the 95% limit, you can observe. If it is outside that limit, you can. The suggestion is to prescribe to bring the uncorrected portion just within the normal range to the 95% limit, and this will keep the stimulus for metabolization. So I'll give an example. So if you have is 3 years old, he has bilateral hyperopia around 5 diopter. This is outside the 95% limit. So you need to give him glasses. So you'll give him to bring him just above the 95% limit. So for example, you'll give him +3 or +3.5. So it'll make him within the 95% limit. Amblyopia eye has less accommodation. You have to take this into consideration when you prescribe glasses, that the amblyopia eye will not be accommodating, so you can give him more hyperop. In anisometropy, the least ametropic eye determines the amount of accommodation, which with the amblyopia eye lagging behind. I'll give an example. So if you have two eyes, if you have a patient with anisometropia and his refraction one eye is +5, for example, and his refraction the other eye is +2. So the eye with a refraction of +2, if it is the good eye, it will drive and determine the amount of accommodation in the other eye, which is +5, because the accommodation is bilateral condition. So for example, the eye will accommodate 2 diopter to see 20/20 and to bring the ametropia into emetropia, so it will be plano. So the other eye also, it will accommodate 2 diopter. So the other eye, it will become +3. But that eye, which is going to be amblyopic, now cannot accommodate more, so it will not be able to see good. So this principle should be taken into consideration when you want to prescribe glasses. In case of strabismus, you should give the full correction according to the type of deviation, of course. When prescribing for school children, always make the full subjective refraction considered. Children with aphakia or seriaphakia require glasses or contact lenses to correct the residual hyperopia, plus a correction for near because they don't have accommodation. Every child or every clinic should make cycloplegia for every patient, because children have low cooperation rate, and because they have a good accommodation. So if you don't do cycloplegia, in most of the cases, you will end up in a wrong prescription. So it's absolutely mandatory to relax accommodation before attempting refraction. Children incomplete cycloplegia often lead to over or underestimation. Cycloventilate 1% is usual and most commonly used type of cycloplegia. You'll find some pediatric ophthalmologists use different type, but this is the most common. You can add phenylephrine 2.5% or tobacamide 0.5%, depending on the physician practice. And we can see here that cycloventilate is used because of good cycloplegia and short onset of cycloplegic effect. We don't need to forget that there are side effects and sensitivity or allergy. It's listed here, no need to go through it. If you have a susceptible child, you think he might have allergy to cycloplegia, you have to, better to do punctal occlusion. And in some cases, if the reaction is severe, you may need to use physostigmine as antidote. This is a famous table from American Academy of Ophthalmology preferred practice pattern for amblyopia. It shows the guideline for correction in infant less than 4 years, and it's solely based on professional experience and clinical impression. But here it's mainly on experience and clinical impression, and the other problem here in this table that it will not tell how much you need to give. This is another guidelines from another study, but this one will shows a review of guidelines. Some of them are based on research evidence and some are based on clinical experience. I will go over each one. I'll go over each one and summarize it in the next slide. So, for example, for hyperopia, if the infant is less than 1 year, suggestion is to prescribe if more than 4.5 diopter to 5 diopter. And American Academy of Ophthalmology preferred practice pattern, they put the limit as 6 diopter. But according to other studies, they found that this is the higher limit of 95% population age. So you should, in my opinion, also if more than 5, it's better to prescribe. You should undercorrect what to give, undercorrect 2 diopter to match the upper limit of the 95% age. Sorry, to match the mean spherical equivalent. Sorry. From 1 year and above, let's say from 1 year to 4 years, prescribe for more than 3.5 diopter. Again, this is, I told you, this is different from American Academy of Ophthalmology guidelines, but it's not a must for everyone to follow, but this is what I found in the summary of the guidelines. So if more than 1 year, up to 4 years, if more than 3.5 diopter, suggestion is to prescribe, and you should undercorrect 1 to 1.5 diopter to match the mean spherical equivalent. And also because you don't need full correction for hyperopia. From 4 years and above, prescribe for more than 2.5 diopter, undercorrect also 1 to 1.5. In school age, prescribe for more than 1.5 diopter and always use subjective refraction. So again, 4.5, 3.5, 2.5, 1.5. Any patient who is amblyopic, you should give full correction regardless of his age. You can undercorrect 0.5 or 1 diopter to match the other eye in anisotropia. For example, I'll give you one example. If you have a child with anisotropia, one eye is +5, the other eye is +2. So if you give him +5 and you keep the anisotropia difference and you give him +2 in the other eye, he might be blurred in the normal eye and he might not accept. So what you can do is to decrease half diopter, 1 diopter of the amblyopic eye and keep the anisotropy difference, and then you give him +4, +4.5, and the other eye +1 or +1.5. Aphakic or sediphakic, prescribe full correction, add 2 to 3 diopter if younger than 4 years, bifocal if older child. In case of accommodation deficit, for example, Down syndrome or other neurological condition, prescribe near to full correction because they don't have accommodation. In case of istropia, you should give full correction if the refraction is more than 1 diopter in older child, and if infant, if more than 2 diopter, you should give full prescription. Of course, if it's less, for example, if infant has 1 diopter of hyperopia, we don't expect it to be the cause of istropia. And also in older child, if he is less than 1 diopter of hyperopia, we don't expect that to be the cause for his deviation. In case of exodeviation, undercorrect 1.5 to 2 diopter if older child do subjective refraction. Again, this is the same guidelines for myopia. I'll go through it. So in infant less than 1 year, prescribe for more than 5 diopter. Undercorrect 2 diopter to because of chance of emetrization, to stimulate for the emetrization. And also because the infant at this age don't need good vision for distance. From 1 year and above, if prescribe if more than 2 to 3 diopter, undercorrect half to 1 diopter, again for chance for emetrization and no need for distance vision. From 4 years and above, prescribe for more than 1 diopter, and no need to undercorrect if you decided to give the prescription. In school age, depend on subjective refraction, and also you need to give full correction because they need distant vision. So again, less than 1 year, more than 5. Above 1 year, from 1 year to 5, more than 2 to 3 diopter. From 4 years to 6 years, more than 1 diopter, and then school age, give full correction. In amblyopia, always give full correction. In aphakia or pseudophakia, prescribe full correction, but you have to undercorrect 2 to 3 diopter if younger than 4 years, because they don't have accommodation. So to help them for accommodation, you should undercorrect. And give bifocal if ordered child. In case of extra deviation in any age, you should prescribe full correction. Again, this is the same guidelines for astigmatism. Infant less than 1 year, prescribe for more than 3 diopter. Again, I repeat, infant less than 1 year, prescribe for more than 3 diopter, undercorrect 1 diopter because of immobilization. From 1 year to 2 years, prescribe more than 2.5, undercorrect 1 diopter for immobilization. From 2 to 4 years, prescribe more than 2 diopter, undercorrect also 1 diopter because of immobilization. If older than 4 years, and from 4 to 6 years, prescribe more than 1.5 diopter and give full correction. Undercorrect if high astigmatism, just to let the child to adapt to the glasses, and then increase to the full correction. So again, less than 1 year, more than 3. From 1 to 2 years, more than 2.5. From 2 to 4 years, more than 2. And above 4 years, more than 1.5. In school age, most of the studies recommend to prescribe more than 0.75 diopter. You should give full correction, and also you should depend on subjective refraction. Now, this is very important. In case of oblique astigmatism, the threshold to prescribe glasses less than other type of astigmatism. So you should give, in case of oblique astigmatism, if the refraction is more than 1 diopter. So if the refraction is more than 1 diopter, it's the suggestion or the recommendation is to prescribe the glasses, because it's an amblyogenic type of astigmatism. What to give if the child is younger than 2 years? You should give 3/4 of the refraction. For example, if his refraction, if his astigmatism +4, you give him +3, for example. Okay, and then in case of extra deviation, give full correction always, because it's associated with improvement in the control. In case of amblyopia, always you should give full correction. The same guideline for anisotropia. Infant less than 1 year, if hyperope or astigmatism, prescribe more than 2.5 diopter because of risk of amblyopia. If more than, in case of myopia, prescribe more than 4 diopter. Again, risk of amblyopia. From 1 to 4 years, in the case of hyperope and astigmatism, prescribe more than 1.5 diopter. In the case of myopia, if more than 3 diopter. For astigmatism, it's milder than hyperope. So you may increase the threshold to 2 diopter, 2 diopter difference in the case of astigmatism. But if you also give, it's not a wrong practice. If there is amblyopia, you should give in any age and any amount. If you have a lower number of anisotropia, which is not recommended to prescribe glasses, you should observe for 4 to 6 months. Then if you have any signs of amblyopia, you should prescribe whatever the amount. Always give full correction for anisotropia. Don't undercorrect. This is an important message. Don't undercorrect the anisotropia. After all we have done, after all examination and meticulous prescription and consideration, you give the glasses, the child comes back to you not using the glasses, not compliance with the glasses. This is very common in pediatric ophthalmology clinic. I'm sure that every pediatric ophthalmology have this experience in his clinic. So then what you need to do? First, I divided the reason for non-compliance into 4 categories to make it easier to memorize and understand. First, personal factor. The child does not like to wear the glasses. It's only behavior. He doesn't want to wear the glasses. So this is the job of the parents to do all maneuvers to help him to wear the glasses. Lack of affordability in the case of financial issue. Then social factor. It's an attractive frame or poor appearance, especially in girls. Negative attitude of the society. Some society, they look to the child who is wearing the glasses as a negative look, or they will tease him or bullying on him. Lastly, parental disapproval. Some parents, they don't like their child to wear glasses. Even sometimes in the clinic, they will accept in front of you, or they will say, okay, give us the prescription, and then they will go out and they will not make it. So sometimes the parents are the responsible for non-compliance. Visual problem. Sometimes the child not see good with the glasses, or he will have headache, or he will complain of headache. So this is one of the causes also. Otherwise, maybe only breakage or loss or forgetfulness of the glasses. What to do? First of all, for me, and I think also for everyone, first of all, you should make a good counseling with parents, because they are the one who are taking care of the child. They are the one who live with the child at home, and they must have some idea why their child don't like to wear the glasses. So you should make a good counseling, understand the real reason for non-compliance, then explain to them the benefit and the risk, the benefit of wearing the glasses, or their importance, and the risk of not wearing the glasses. You should also warn them that vision will be lost. The child will go into deep amblyopia. He will not have the a chance of acceptance in military, for example, in military field or whatever, or medical field. So you should warn them with the strong words. Check the glasses and the prescription. Sometimes even if even if you are sure about yourself and you are sure about the prescription, sometimes you'll find the glasses wrongly made by the optical shop. So you have to double check it with your previous prescription. Sometimes you find the lenses are mistakenly reversed by the parents, and this is very common. You find one of the lenses or 2 lenses fall down, and then it's reversed by the parents, or sometimes by the child himself. Like visual problem, you should, if the child is not wearing because of not seeing well or have headache, you should repeat cycloplegic. In case of hyperopia and difficulty with accommodation and adapting to the new glasses, you can give atropine for 2 weeks. In some situation, you can undercorrect to help the patient to adapt for a short period, then you increase it to the full correction. This is in case of, for example, high astigmatism. Sometimes you may need to undercorrect for a short period and then increase it gradually. Lastly, if the patient family or parents have a problem, financial problem, the only way is to send them to healthcare social worker to provide them with financial support or psychosocial support or whatever. In conclusion, for hyperopia, give full correction is deviation and amblyopia, otherwise undercorrect. For myopia and astigmatism, undercorrect if the child is less than 4 years, otherwise give full correction. For amblyopia, always give full correction. For anisotropia, always give full correction. In easy deviation, always give full hyperopic correction. In X deviation, give full myopic and astigmatic correction. Now I finished, but I make some cases for the student. Let me. This is case number 1. I will show the case, and I want one of the residents to answer. Then I will show the correct answer. Okay. 1 minute. Let's say you have a child who is 4 years with intermittent ESO deviation. His refraction in the right eye is plus 2.5, in the left eye plus 2. What you give? I want one volunteer.
Yeah, Doctor, we have Dr. Arim Al-Ahmadi wants to answer.
طيب, okay.
All right, this is assuming that this is a cycloplegic refraction, or this is the dry refraction.
No, cycloplegic. All the refraction is all the refraction shown here is cycloplegic refraction. Yes.
Okay, since this is a ESO deviation with hyperopia, I would refract the full hyperopic
okay.
glass.
Yeah, this is correct. Okay. Excellent. This is a good answer. You should give the full correction because of ESO deviation. Case number 2, another volunteer, please. Child the same age, 4 years, with intermittent X deviation. This is his cycloplegic refraction. Assuming that he has equal vision in both eyes. Who's going to be a volunteer?
Anyone wants to answer?
Dr. Nora is here. Nora.
Nora Al-Yusuf.
Yes.
Assalamu alaikum.
Yes.
Yeah.
This a child, he's +4 both eyes, and he's having intermittent XP. So I will undercorrect him by like 1.5 or 2 diopter.
You are right, but first of all, you should look to the number of his hyperopia. It is +4, so it is in above the range of for his age. So if it is, for example, +2, you don't need to give. This is +4. You need to give him the prescription. Continue, but we have to undercorrect. Yeah, continue. Yes. So how much you will get?
I will give like +3 both eyes.
+3 is not the appropriate refraction. Appropriate prescription, because you need to undercorrect more to stimulate his accommodation, to help in improving his control for the X deviation. So I would undercorrect 1.5 to 2 diopter, making sure that this will not affect his vision. Okay, so I'll give +2 or +2.5, depend on clinical condition or situation. I'll go to case 3. I want another volunteer, please. This is 2 years old child with intermittent X deviation. As this is a cycloplegic refraction. Yeah, can I have another volunteer, please? Should I name?
Yes, there's no one wants to participate so far.
دكتور عبد الرحمن خان موجود؟
عبد الله خان.
لا، عبد الرحمن. أو عبد الله بس عبد الرحمن.
عبد الرحمن يس أروى.
السلام عليكم دكتور.
أيوه.
تفضل عبد الرحمن.
So this is 2 years old child with intermittent exodeviation, and he's myopic in both eyes. So since he's having exodeviation, I will give him the full cycloplegic correction.
Yeah, excellent. To explain it, if the child has no deviation, you can observe. No need to give the glasses. If the child has exodeviation, you should give him the full correction because of his deviation will be improved by the full correction of myopia. So we have to give full correction. طيب, case number 4. Again, can I see another volunteer? دكتور عبد الله خان موجود ولا؟
Can I have a question, دكتور؟
يا تفضل. من اللي
for the previous محمود عتيبي. الله يعافيك، كيف حالك دكتور؟
سهلا، تفضل.
كل عام وانتم بخير إن شاء الله. دكتور بالنسبة للثيرد كيس can we over minus the patient?
Depend on the clinical condition and examination finding. Over minusing is one option of one option of non-surgical method of management of intermittent exodeviation. But for me, if a child has myopia, you should give him first the full correction. Then, if he did not improve, then the time where you think of overcorrection. Overcorrection here, you can use it, for example, if patient is plano, then you can overcorrect. But this is already, he has myopia, so just give him the refractive correction. In my opinion, in this situation, I will give first the prescription, and then I will observe him and see how is he dealing with prescription. If he has improved control, I will keep his glasses. If not, I may think of other option, either alternate batch or over minusing.
Thank you, Doctor.
السلام عليكم. الله يعطيك العافية دكتور سيف. معك عبد الله خان. So this is 4 years old child with normal exam. First we have to check the vision. Is there amblyopia or no? If there is amblyopia,
there is amblyopia.
Regarding the refraction, we will try to give him, like, for the left eye, we will give the full correction.
طيب,
we will subtract for the age, like maybe for the left eye we will keep him +1, and for the right eye we'll give him +4, like under.
You can give full correction. Some children with full correction, they will not accept the glasses because they depend on the good eye, which is the left eye, and it will be blurred if you give them the full correction. So one way is to under-correct the correction in the left eye. You give +1 or +1.5, and then either you match it in the right eye or you give full correction in the right eye. So there is 2 ways: either you give +5 and +1 in the left eye, or you give +4.5 or +4 in the right eye. And then also you can observe the child for example 6 weeks, and then if he does not improve, you should give full correction. But the point here is to give full correction in the right eye and to keep the anisometropic difference. Okay, so either you give him under-correct either 3.5 or 4 diopter. No, I think this is by mistake. You under-correct 1 diopter in the left eye, and in the right eye either you give +4 or +4.5. This is by mistake. Okay. طيب okay. So yeah, for this scenario, you should give either full correction or you under correct half to 1 diopter just to help the child to accept the glasses in the good eye. And no need to batch because the recommendation now is to start only with refractive correction, and if not improved, you can start batching the next visit. طيب case 5. Sorry. Yeah, sorry. So case number 4, he has the normal vision. In the case of normal vision, we can undercorrect both eyes if the patient has normal vision. And then if the case of amblyopic eye, you should give the full correction, as I told you. So let's go to case number 6. 2 years old child with no deviation. This is his refraction.
دكتور سيف ممكن سؤال بالنسبه للبريفيوس كيس. We said let's say here with amblyopia we give the full correction as a rule, but if you notice in the previous example, case number 4, here you undercorrect the child, and the reason is that because the child will have accommodation and he will accommodate for 1 diopter in the left eye, and subsequently will accommodate 1 diopter in the right eye. So at the end, he will have like +5 in the right eye. Correct?
No, I didn't understand your question.
So here we undercorrect by 1 diopter.
Yes, exactly.
We let the patient to accommodate by 1 diopter.
Yeah, okay. We undercorrect 1 diopter to
let the patient to accommodate.
Yes.
What if we did the same with amblyopia? Like in the next, he can see when he will, if we give him +1 only for the left eye, he will accommodate for that 1 diopter. And in the right eye, we'll give him +4. He will accommodate because the accommodation is bilateral.
The amblyopia eye has less accommodation than normal, and this is confirmed by multiple studies. Even though accommodation is bilateral, but they found that the amblyopia eye has less accommodation than normal eye. So if you undercorrect the amblyopia eye, the child will not be able to see good because of the remaining hyperopia. He's unable to accommodate the remaining part.
واضح الله يعطيك العافية.
Okay. طيب case number 6.
طيب نقبل when to answer.
طيب كيف ناخذ من
يعني ما في unmuted.
طيب دقيقة ايش 1 minute. طيب in the chat يعني anyone can answer in the chat. How can I see the chat? I want to see the chat.
من تحت.
Yeah, here. So
طيب
can I see?
cannot hear you. So if الدكتور أحمد العتيبي wants to answer.
طيب either he can write it or yeah.
Assalamu alaikum. Since the patient has no deviation, I would consider correcting the astigmatism, the cylinder, plano with cylinder.
Excellent answer. Because he has 3 diopter of astigmatism, and this is above the normal for age. We should give the prescription, and we in the spherical part, which is the hyperopia, he has within the normal range and no need to give prescription, so we can give him plano, and either you give him full correction or you undercorrect half diopter or 1 diopter. طيب 1 minute. So either you give him full correction or you can undercorrect half diopter of both cylindrical power. And no need to give the hyperopic part. Excellent. طيب, this is case number 7. I want to see the answer in the chat, and then yeah, I want to see the answers. No correction. No, you have to give correction. Anisotropia, so correct, yes, we have to correct. -2 plano. Yeah, this is the excellent answer from Dr. Ghaida. Excellent answer. We have to correct myopia to allow for immobilization. No need to give full correction for myopia, but we have to give glasses. So what we need to do is to, either we give, there is a problem here that a child has anisotropia, so we cannot undercorrect him. If we want to undercorrect, maybe we can undercorrect only 1 diopter. So either we give him -4 plano full correction, or we give him -3 in the right eye and plano in the left eye. Yeah, we have to give him the, what about Amblyopia? Yeah, we have to give him either full correction or you undercorrect only 1 diopter. The child is 6 months old. Maybe he didn't develop amblyopia. We have to evaluate his vision and observe him. Yeah, exactly. If a child is more than myopia and anisotropia, to correct more than 4 diopter, yes, right. True, yes, right. Dr. Yasser, yes, right. If the child is 3 years old, again, you will give him, because the criteria for 3 years old is to give the correction if more than 3 diopter. Batching, again, we said that the batching will be after a prescription after prescription given for 6 weeks, and then in the second visit you can see if the child still have amblyopia, you start batching. This case, no need for correction. No, you have to give correction. Either you give full correction or you undercorrect the amblyopic eye 1 diopter only. Let's go to the next. We will open the floor for discussion, but let's go for the next case here. The same child, the same age, 6 months old with no deviation. He has bilateral myopia -6. So what we will give? Yeah. All of you get the, yeah. This is a good answer. Yeah. Undercorrect because of bilateral, no anisotropia. Undercorrect 2 diopter. Yes, excellent. This is a good answer. The last case. Excellent, -4, both eyes. This is my last case, and then we'll receive the questions. 3 years old with pseudophakia. OU, what you will do, or how much you will give? Let me see the answer first. We need to give him the full, we need to give him the prescription because he's pseudophakic, and we have to overcorrect. +2, no, we have to overcorrect, either +4 or +5, depend on the situation. Yeah, excellent, either +4 or +5, depend on the situation. If a child is older, you can give him bifocal. Yeah, excellent, +4 or +5, yeah, this is correct. Like now I am done, so I will receive only questions from the resident. 1 minute. Yeah, we'll give +4 or more, depend on the child's situation. Thank you. I want to receive the questions if there is any questions. I will see the chat and then I will take some questions to answer. Thank you, thank you. I think you are welcome, all of you. You are welcome, thank you. Any questions? Thank you, Dr. Raida. Up to what we can give bifocal in case of pseudophakia? Up to what? Up to what age? We have to give all the time bifocal. Maybe your questions means from what age we have to prescribe bifocal? From 5 or 6 years, in my opinion, but it depends on the physician himself. Up to what age? No, up to old age. ما خلاص he will stick with the bifocal. If there is progressive myopia, what is the mode of treatment? If I understand the questions, the question is what is the treatment of increasing myopia? You have to look for the cause. Is the child having a sign of ectasia, for example, or pathological myopia? For me, I don't use atropine. Dr. Amal Ahmedan has great experience with atropine therapy for myopia, but for me, I'll give only glasses and I'll observe the child. I don't use the atropine treatment. If there's what is the mode of treatment? Age 12 years, I'll give full correction. I don't give atropine in my practice. Any other questions, or will?
Doctor, there is one question. Can you please repeat how to correct hyperopia with amblyopia?
Hyperopia with
amblyopia.
amblyopia. طيب. Unilateral pseudophakia, they need bifocal for near, but sometimes you don't give bifocal because the child will depend on his good eye for near, and he will use the pseudophakic eye for distance. So sometimes you may not give bifocal, or you may need to, no need for add. Yeah. Dr. Siham, this is a question from Dr. Siham. Thank you, Dr. Haidar. I didn't start, maybe I will consider it later. Maximum tolerable myopic glasses. If I understand the question is what is the maximum number of myopia to give in the glasses? I give even if high myopia. I offer contact lens if the family are affording to use it, but if not, I will give only prescription in glasses. It helps. I'll go back to hyperopia with amblyopia. Okay, 1 minute. Hyperopia with amblyopia, any age, prescribe full correction. You need to give the full correction for the amblyopic eye. You can under correct half to 1 diopter to match the other eye in anisotropia. This is clear in the case of one eye +5, and the other eye is, I will write it down here. I hope show up in the screen. So let's say the right eye D is +5 and left eye is +2. طيب, in the case of amblyopia in the right eye, you should give the full correction, or you can undercorrect half to 1 diopter to match the other eye in anisometropy. So you either you give right eye +5 and the left eye you give +2, or you can undercorrect both, so it will be +4.5 in the right eye and then +1.5 in the left eye. We have to keep the anisotropic difference يعني not decreased or not undercorrected significantly, because this will affect the accommodation. So, sometimes you can undercorrect half diopter. Here you undercorrect half diopter in the amblyopic eye prescription. طيب. Is the Eugenic anisotropic the same of sphere and cylinder? I didn't understand the question. Case of 6 months with anisometropia -4 and plano. With full correction, blur his vision, and can we undercorrect if the child does not need far vision? In this example, the anisometric difference is the cause for it is the cause for or it is the indication for the prescription. In the case of -4 and plano, the indication is the anisometropia, which is 4 diopter in case of myopia. So we have to keep the difference of anisometropia, or if you want to undercorrect, you undercorrect in the good eye, half diopter or 1 diopter, not to decrease or undercorrect the anisometropia significantly. So this is why we need to give either full correction in the eye with -4, or you undercorrect 1 diopter only, half diopter to 1 diopter. The child has XT of 20 and also has myopia. Would you over minus in this patient? If child has myopia, start with full correction only, and then see what happens. If still the control not reaching the appropriate control or the good control, either you try alternate batch, or you may consider over minusing in the next visits. Dania 0.01 atropine, I didn't write, maybe later on. Regardless of the degree of XT. Thank you very much. طيب, I think خلاص I received many questions, so thank you everybody. We're gonna finish here. طيب, the last question, if in the case of -10 and plano, I'll give full correction, because this is too much. You have to give full correction. طيب, thank you everybody. I will end here.
Thank you, Dr. Saif.
Stop share, huh?
Okay.
Yeah, thank you.